Welcome to Introduction to the Cardiac Cath Lab. My name is Morton Kern. I'm Associate Chief of Cardiology and Director of Interventional Cardiology here at University of California, Irvine in Orange, California. Today we're going to talk about how the cath lab works, how we do cardiac catheterization procedures, talk about the basics of vascular access, the fundamentals of coronary angiography and left ventriculography. We're going to introduce you to some of the techniques, methods, and images that we acquire in the cath lab to make our diagnosis of patients who have principally coronary artery disease, but also valvular heart disease and other cardiac problems that require invasive assessment. Now, we have a cardiac catheterization handbook which details some of these concepts in writing, and it's been a popular book used by people who train in the cardiac cath lab. But this video will help us see actually how these techniques are employed and give us a better idea of how to use them if you're not familiar with that. We'll start with some of the indications for cardiac catheterization. There are approximately 1 million of these procedures performed every year in this country, and around the world even more. Indications for cardiac catheterization include reasons to investigate causes of chest pain due to coronary artery disease, suspected coronary artery disease, patients who have heart attacks or are suspected of having heart attacks, patients who have valvular heart disease or other known cardiac problems. In addition, cardiac catheterization is indicated for patients who have shortness of breath of an unknown etiology in which we have a high suspicion of cardiac disease. When we talk about patients who are having indications, we also have to cover those patients who cannot have cardiac catheterization. Now, there is no absolute contraindication to the procedure. It is a life-saving procedure in patients who need it, but relative contraindications do exist. That is, for elective cardiac catheterization, we want to make sure the patient is well treated with medicines appropriately, stabilized with regard to his chemistries, his kidney function, his electrolytes, make sure that he's not unstable or unnecessarily unstable, to be able to lie flat on the table so they can breathe. Those patients with heart failure should be treated, and those patients should have a good understanding of why they have the procedure. If they cannot understand, they cannot consent. And then, of course, if the equipment in the cath lab is not working, that is the only absolute contraindication to the procedure. Let's talk for a moment about the risks of cardiac catheterization. Because we work in the vascular tree, we're always subject to inducing a risk of the procedure. The risks are serious but rare. They include heart attack, stroke, and death. These are generally quoted at 1 person in 1,000 to have one of these serious risks. There's a less serious risk of bleeding at our puncture site, especially the femoral artery, in which the need for a transfusion or a surgery to close an artery that won't stop bleeding is about 1 person in 250. We now have vascular closure devices which make this technique even safer. When we move into the field of interventional cardiology and talk about angioplasty and stent placement, we increase our risks more. Approximately 1 person in 500 may have the risk of a stroke, a heart attack, or death, and bleeding is a little higher because we use more intense anticoagulations. Now, when we talk to patients about having the procedure, we need to obtain their consent, and the consent is done after the physician talks to them about how the procedure is done. So I'll just tell you exactly what I would tell our patients having a cardiac procedure. So we're going to do a coronary angiography today, and we'll probably do an angioplasty if we find a blockage. I would explain that we would give him some numbing medicine over the femoral artery. There won't be any discomfort. We'll introduce catheters, which are described as long, thin pieces of plastic tubing, like spaghetti, which is very small and passes up the artery to the heart without any discomfort, because there are no nerves on the interior of the vessels. We then would seat the catheters and inject about a tablespoon or so of iodine contrast material. And we would do this with an X-ray machine that moves across the chest so we could take pictures of the arteries in the heart from different angles. After we had our pictures, we would understand where the blockages were. We would take the coronary catheters out and put in a catheter to take a picture of the main pumping chamber, the ventricle. We would see how the ventricle works during injection of contrast into the ventricular chamber, again about another tablespoon or two of contrast material, iodine solution. We would take that catheter out after the completion of the imaging, and we would then make a decision whether we needed to proceed to angioplasty or not. If we found that the arteries were not in need of angioplasty or normal, we would then take our catheters out. We would put a vascular closure device or perhaps manual compression to seal the femoral artery, and we would discharge the patient 4 or 5 hours later after the patient received some fluids and was recovered from his conscious sedation. If we did angioplasty, and it's generally performed by putting in a stent, a small metal spring-like structure to hold the artery open. If we would do the placement of the stent, then we would finish our procedure, again remove the catheters at the end of that, put in a vascular closure device, and keep the patient overnight in our hospital, either in the intensive care unit or in a specific area for our post-PCI, standing for percutaneous coronary intervention, our post-PCI patients in whom we would monitor them overnight and discharge them in the morning. Of course, appropriate medications would be needed for their discharge, especially Plavix for any stents that were placed, and other medicines for patients with known coronary artery disease. Our routine follow-up would be in a month or so for the stent patients depending on their clinical needs. So those are our introduction to the cath lab. We have our indications, our contraindications, our risks, and our technique of consent. I just want to remind the viewers that this is a team approach. There is no single member of the team who can do this by themselves. The physician has an assistant. The assistant can be a technician or a nurse. The team at the table, the doctor and the technician or nurse, have an associate who circulates, another technician or nurse, to help provide equipment, monitor the patient, and move some of the X-ray equipment as needed. In many laboratories, there may be a radiology technician involved who is specially trained to handle the X-ray equipment and help us obtain the images we need during cardiac catheterization. In addition to these individuals in the room, we often have a nurse or technician monitoring the patient from outside at our recording station to record the blood pressure, hemodynamics, and make sure that the imaging data and log of the procedure are adequately acquired. I want to show you our equipment. Every cath lab has a C-arm. That's this structure here, in which the X-ray generator is found at the bottom. X-rays are generated from the X-ray generator and pass vertically up to the image intensifier. The X-rays are collected, an image is created on the image intensifier, and in newer systems, these image intensifiers are flat panel. The signal of the image is then transmitted to the video chain. It's converted into digital imaging in this system, or it comes directly as a digital image, is then transmitted to the image display areas, which are in this room 2 video monitors. X-ray rooms are lead lined, as this one is, and there is lead shielding available to protect the operators, because they're in the cath lab every day. These lead shields protect the operators from excess radiation scatter. So X-rays come up through the patient. When they hit the bony structures, they're scattered, and the highest areas of X-ray exposure are those closest to the X-ray generator, and they are blocked with lead shielding above and at the waist level and below, and also a movable shield here, which has lead, and a lead shield to protect the operator's upper body, face, and arms. Now, beside the shielding that's present for the table and the room, the operators themselves wear lead aprons and a lead thyroid shield. Some individuals wear lead glasses. Now, we use radiation in 2 ways in the cath lab. When we step on our activation pedals, which are shown here in the bottom, these pedals have triggers for fluoroscopy only, which is this flat pedal, or for the activation of the cine angiographic mode, which has 10 times the radiation dose delivered because we have to record those images on our video chain for storage. So we have the ability to do fluoroscopy and cineangiography with those different petals. And in this particular cath lab, we have a second C-arm, which is shown behind me, having a second X-ray tube system, and we call that biplane. So we have two planes, and that's why we had two sets of petals for our X-ray generation. This next section shows us needles used for vascular access. There are many different kinds of needles available, the most common of which are long femoral needles of 16 to 18 gauge diameters and shorter micropuncture needles used for both femoral and radial access. In general, the brachial artery should not be an access site of first, second, or third choice. For the access site needles for the femoral artery, it is common to have a marker on the plastic hub indicating which direction the bevel is facing. There may be a protective shield or flange which makes handling the needle easier. The needles are of about 2.5 inches in length. For the micropuncture needles, these are generally 21 gauge needles. Some have a long segment, others are short segments. The micropuncture needles create a smaller entry hole and less back bleeding is identified, but they are excellent for radial access and can be used for femoral access. Vascular sheaths are used to maintain access once vascular access through needle puncture and wire insertion has been accomplished. These vascular sheaths they come in varying lengths and varying diameters. They have a valved end through which the catheter passes easily and prevents back bleeding of blood. The sheaths are generally color-coded, ranging from 8 or 9 all the way down to 4 French in diameter. The sheath comprises 3 major parts. It has a straight shaft through which the catheters pass, and on the end of this is the valve accepting the dilator. This dilator is manufactured with a central hole accommodating 0.038 inch guide wires, and in some cases the sheaths are designed specifically to accommodate only the micropuncture guide wires of 0.018 inches. Attached to the side of the valve is the side arm, which can be used to flush the sheath, and it has a stopcock at the end of it to control bleeding or permit introduction of medications. These sheaths are flexible and strong, but they can be kinked if they are flexed to too great a degree, and they are generally coated for easy entry and safety. Guide wires are spring-coiled, soft safety guide wires with tips that can be flexed and are introduced either through the access needle, through the sheath, through catheters, and are used to advance catheters and sheaths, and also to exchange catheters and sheaths once vascular access has been obtained. These wires vary in diameter, in consistency, in weight, in strength, and are designed for specific applications. The most common guide wire used is a 38 flexible J-tipped guide wire in a 180 centimeter length. These guide wires come in 0.035, 0.022, and even fine angioplasty type guide wires in 0.018 inches. They are flexible at the tip, which enters the body, and stiff at the other end. Exchange guide wires come in 300 centimeter lengths, which permits the operator to position the guide wire in the distal part of the heart or arteries and then exchange for different catheters. Catheters are long, thin tubes like pieces of spaghetti made of plastic. The designation JL4 or JL3.5 indicate Judkins left 4 centimeter, indicating the distance between the tip and the secondary curve. The ventriculography catheters, the most common one in use is that of the pigtail catheter, which has an end hole, the curved pigtail portion, and just proximal to that curved pigtail portion, 6 side holes are punched to permit contrast to exit the catheter through these side holes and a little bit through the end hole so that a cloud of contrast material forms rather than small jets which can irritate the myocardium or even in some cases perforate this. These pigtail catheters can be obtained in either a straight configuration or a 145-degree angled configuration. For the Judkins Wright, the JR4, there are generally very few indications to use a shorter JL secondary curve. Specialty curved catheters are also available. These include the multi-purpose catheter, a right bypass graft catheter, a left or right internal mammary catheter. Cardiac angiography is most commonly performed by manual injection through a cardiac manifold. These manifolds may manifest with 2, 3, or 4 ports which are aligned by stopcocks, the handle of the stopcock indicating the off position. The 3 stopcocks most commonly used in a 3-bar manifold contain the pressure port, the flush port, and the contrast port. The clear syringe is important to appreciate any air bubbles that may be accidentally aspirated, and a rotating connector on each end of the manifold makes this an easy tool to use, permitting flexibility in the operator's positioning. It is important to always keep the end of the manifold syringe at least 30 degrees elevated from the table so that any bubbles that do enter the manifold will reside at the plunger end and not be injected into the patient. An indiflator is coupled with a angioplasty guide wire introducer and a angioplasty torque tool. The torque tool is color-coded. It is a small pin vise which permits rotation of the angioplasty guide wire. The angioplasty balloon is inflated with an indiflator device which provides atmospheres of pressure to inflate the small balloon. This is delivered through the manometer, which is filled with a mixture of contrast material and saline, and delivered up to atmospheres ranging from 1 to 2 atmospheres all the way up to 20 to 22 atmospheres of pressure. This is easily to see visibly and is designed for quick inflation and quick deflation. The patient enters the cath lab and is transferred to the X-ray table. The nurses then prepare the patient for the imaging and vascular access. The electrocardiographic leads are applied to the chest. The patient is checked for a working IV. The emergency equipment are prepared for the patient. The groin preparation is then performed for those patients having femoral access. At this time, if radial access was planned, both femoral and radial approaches would be prepared. The patient hair is clipped. Chloroseptic solution is then applied to both groins, and finally, draping will occur shortly thereafter. Sterile technique for applying the chloroprep is used for both sides, and the drapes will then be applied by the sterile scrub tech. The sterile drapes have 2 holes cut in them, which are positioned directly over both femoral arteries. These holes permit access to the skin with minimal exposure of any other area. Assistants drape the entire table so that there is no area of the operating field which is not sterile. It is important to position the holes over the femoral artery and vein, and this is done by palpation and slight adjustment of the access ports. Once the drapes are in place, the connecting tubing for the injector system is passed off the field, and connection to the angiographic injector is made. Pressure manifolds are connected, and then access is obtained. It is important to consider drugs used in the cardiac cath lab, and we'll now review those common drugs used for treatment in the cath lab. We'll discuss briefly those drugs used for sedation, the antiplatelet agents, antithrombotic agents, antiarrhythmics, and vasodilators and vasopressors. Sedation should be appropriate for the American Society of Anesthesia classification. The most commonly used drugs include fentanyl, 25 to 50 micrograms intravenously, Versed 0.5 to 1 milligram intravenously, or on occasion, and now more rarely used, morphine 2 to 4 milligrams intravenously. Reversal agents for benzodiazepine include flumezicil 0.2 to 1 milligram intravenously with a maximal dose of 1 milligram per dose or 3 milligram per hour. Narcan or naloxone hydrochloride is also used to treat narcotics and diluted as indicated on the screen. Antiplatelet agents commonly used in the cardiac cath lab include aspirin in doses of 75 to 325 milligrams daily, clopidogrel, also known as Plavix, 600 milligram bolus loading at the time of angioplasty with a 75 milligram daily dose thereafter, or alternatively ticlopidine, also known as Ticlid, 500 milligram oral loading dose with 250 milligram orally BID. The preferred drug in 2010 is now clopidogrel. Antithrombotic medications include unfractionated heparin, given 50 to 70 unit per kilogram bolus intravenously, or low molecular weight heparin at 0.5 to 1 milligram per kilogram intravenously, or finally direct thrombin inhibitors, which can be used as an alternative to the heparins. These are bivalirudin, also known as Angiomax. The dosage is 0.75 milligram per kilogram bolus with a 1.75 milligram per kilogram per hour infusion. Please compensate for those patients in renal failure. Antiplatelet agents used for PCI most commonly are those of integralin or Riapro. Eptifibatide, also known as integralin, is given in the dosage indicated. And for acute ST elevation myocardial infarction, the preferred glycoprotein 2B3A inhibitor is that of abciximab, also known as Riapro, again administered in the dose shown on the screen. For the treatment of vasovagal reactions manifest by hypotension and bradycardia, atropine in a dose of 0.5 to 1 milligram IV every 3 to 5 minutes to a maximum dose of 2 milligrams or 0.04 milligram per kilogram is administered. In the treatment of supraventricular tachyarrhythmia or when intracoronary or intravenous hyperemia is required, adenosine is the drug of choice. For the treatment of supraventricular tachyarrhythmia, 6 to 12 milligram IV bolus with flush is used to break rapid supraventricular tachycardia. For the treatment of no reflow, intracoronary adenosine has been used in doses ranging from 50 to 200 microgram boluses. For the determination of fractional flow reserve, intracoronary or intravenous adenosine is required. Intravenous dosage for hyperemia in the calculation of FFR is 140 microgram per kilogram per minute infusion, usually for about 4 minutes. Peak measurements are obtained at the 2-minute interval. For intracoronary hyperemia, 12 to 24 and now up to 30 micrograms for right coronary artery has been given, and between 40 and 60 micrograms is now the current dosage for left coronary induction of hyperemia. However, maximal hyperemia can be obtained with the doses shown on this slide. Acetylcholine is a rarely used drug used to test endothelial function. It induces vasodilatation in normal arteries, that is, arteries with normal endothelial function, and causes vasoconstriction in those arteries which have abnormal endothelial function. This test of endothelial function is generally carried out under research protocols only, and the dose of 20 to 100 microgram intracoronary is administered in an infusion mode. Acetylcholine will induce significant and severe vasoconstriction in higher doses, and it will induce coronary vasospasm in patients with a propensity for coronary vasospasm. Caution is needed when using this drug. Papaverine is an arterial vasodilator used for the treatment of peripheral arterial disease and in the past used to test coronary vasodilatory reserve. Doses of 4 to 8 milligrams for the right coronary artery and 8 to 12 milligrams for the left coronary artery induce maximal hyperemia in approximately 30 seconds, and the hyperemia can last for up to 2 minutes. However, papaverine is no longer used in this purpose since it also causes prolongation of the QT interval and has been associated with a torsade de pointe or ventricular tachycardia requiring cardioversion, period. For this reason, adenosine has replaced papaverine for coronary hyperemia. Ergonovine was used to induce coronary vasospasm. Unfortunately, ergonovine malate is no longer produced or available in this country. Methyl ergonovine malate is available for use, but is rarely employed since the diagnosis of coronary vasospasm is made on clinical grounds. Sequential dosing of ergonovine was used at multiple intervals, recording electrocardiographic and angiographic changes at each dosing interval. This should be performed in laboratories familiar with the management of coronary vasospasm and is generally reversed by intracoronary nitroglycerin. Drugs for the use in the treatment of no reflow. After coronary intervention, especially in the acute ST elevation MI or in the treatment of saphenous vein grafts, no reflow or slow reflow may occur. Multiple drugs have been proposed to treat no reflow. Listed here are the most common drugs used to manage and treat no reflow. These include nitroprusside, nicardipine, verapamil, diltiazem, and adenosine in the doses shown. Patients in the cath lab may develop hypotension and require pharmacologic support in the way of applying vasopressor drugs. The most common vasopressors are listed here, which include phenylephrine, also called neosynephrine, norepinephrine, known as Levophed, vasopressin, and epinephrine. Epinephrine is the least often used and should be reserved for patients with minimal coronary artery disease. Nitroglycerin is a common vasodilator used in the cardiac cath lab. It is given to relieve ischemia, reduce coronary spasm. Doses between 100 and 200 micrograms are commonly given intracoronary. Preparation of the cath lab requires many supplies and disposable equipment. In the cath pack, you will find the sterile package opened and syringes shown in color coding on the lower left, gauze, tubing, manifold, flush containers, sterile drapes, safety needle holder, and a variety of other needles, equipments, and wires. This cath pack is designed specifically for the uses in a particular laboratory and may vary from laboratory to laboratory. Hemodynamics in the cardiac cath lab are performed for various indications. When we talk about hemodynamics, we talk about both left-sided heart pressures, that is ventriculography, and the pressures measured during the ventriculogram, and we talk about right heart pressures, those pressures made for diagnosis of specific conditions, which are generally listed here. These include dyspnea of unknown cause, a confirmation of abnormal echocardiographic findings, a confirmation of new clinical findings that may occur between the time of scheduling a procedure and the performance of the procedure. The measurement of hemodynamics is routine for teaching centers, and of course we use those for special studies to learn more about the heart. Let's take a look at some of our tracings. When we go to obtain these tracings, first we have to discuss appropriate setup. This is basic to the cath lab requirements. We'll talk about the cardiac cycle from which these pressures are generated. I'll show you many examples of both normal and abnormal pressure waves, and then discuss in brief some of the pitfalls and artifacts that you may encounter. Common to all cath labs is the initial setup, and this requires making sure that your transducers are zeroed, the transducer height and transducers are calibrated, connections are tight without leaking, the air bubbles are free and cleared out of the system, and that your recorder is not on a wrong calibration factor. You can see that these cables hooked into the back of the cath lab table, which transmit the hemodynamic signals from the transducers, may not always be clear and hooked up correctly, and sometimes they get jumbled. It's important to fix those connections and make sure that they represent the right transducers to make the acquisition of pressure measurements easy. It's always important to have correct catheter preparations on the back table before you start your procedure. Make sure your cardiac output and thermodilution equipment is working, and have available heparinized syringes for the measurement of oxygen saturation. When we talk about patient preparation, that means the right indication for performing the procedure, adequate intravenous lines for administering our medication and drugs which we may need to give, always have an adequate electrocardiographic tracing, make sure the pressure lines, transducers, and outputs are clear and hooked up, and that we have all the equipment we need for the study on the back of the table. This is a typical cath lab room with the recording station here, where our monitoring person is looking into the room to acquire the signals that we're generating at the table side. A team effort is required, and that's why it's worthwhile talking about this before we even engage in discussing the tracings that we will be using. Probably the most common catheter used for right heart pressure measurements is that of a balloon-tipped flotation catheter. Here you see this balloon-tipped catheter, which has several ports, a proximal port, a distal port, and another lumen which transmits air to the balloon on the end. This inflation syringe delivers air into this balloon. The balloon is then inflated and easily floats through the system. And it's a very safe catheter. It revolutionized the diagnosis of heart disease back in the 1970s, and now is a mainstay both in the cath lab and in the intensive care unit for right heart pressure measurements. Now, there are errors that can be introduced because of our pressure measuring systems, and these include the temporal delay of pressure as it moves through fluid-filled systems. The use of non-simultaneous pressure recordings is a source of error. An incorrectly damped pressure signal, either over-damped or under-damped, can produce problems. Calibration errors and the flow dependence of valve gradients is critical to accurate valve area calculations. Rarely does a catheter interfere with stenotic valves, but in the past that has been reported as a source of error. Before we get into the cardiac cycle, I wanted just to show you a picture of the anatomy of the heart. So if we look on this MRI image, we see the right atrium and the tricuspid valve, the right ventricle, the interventricular septum, the left ventricle, and the left atrium. Now the two small atria both have atrioventricular valves, and they contract generally at the same time. They deliver booster pump flow into the ventricles, and the ventricles both conduct generally at the same time. So you have two low pressure systems, two higher pressure systems, and of course the left side is the very high pressure ventricle or pump of the heart. And as we'll see in just a moment, these pressure waves that we'll be recording are generated through these mechanical activations. Blood flow through the heart is strictly a pressure-driven phenomena. That is, the lowest pressure in the heart is the right atrium, and it moves through the heart through pumping actions, ultimately circulating to the body. Now this particular example had a patent foramen ovale with a clot, but that's really not the point of our anatomy example. Now everything we need to know in hemodynamics is actually displayed on a diagram such as this that was generated by a Dr. Wiggers in 1932. And what Dr. Wiggers told us was that for every electrical activation, there's a mechanical event that follows. So on the electrocardiogram, when the P wave activates, it triggers mechanical contraction of the atria, producing an A wave. A wave is followed by a relaxation or an X descent. The next electrical event that occurs is the QRS, which initiates ventricular contraction, and as pressure builds in the ventricle, the atrioventricular valve closes. Pressure increases in the ventricle without anything happening. This is called isovolumetric contraction. And when the pressure in the ventricle exceeds that of the aortic valve, or in the right ventricle, the pulmonary valve, the semilunar valve opens. The semilunar valve is now open. The ventricle continues to contract and expel the blood until the electrical signal indicates repolarization. When repolarization occurs, ventricular relaxation starts, pressure falls, and when ventricular pressure falls below aortic pressure, the aortic valve closes at that point. The aortic valve closes, pressure in the aorta continues to bleed off to the peripheral circulation, and pressure in the ventricle falls without changing volume. This is called isovolumetric relaxation. And when pressure falls below that of the left atrium, the mitral valve opens and the atrium empty into the ventricle. And that is the cardiac cycle. The A wave is generated from atrial contraction. The systolic wave is generated after the QRS. The diastolic portion of the cycle starts after the T wave. And that is the whole genesis of our waveforms. Here's another example of those findings. Atrium with an A wave and a V wave. There's an X descent, a C notch, a V wave, and a Y descent. Your arterial pressure is shown here. I think it's shown here, superimposed on the left ventricular pressure. And different portions of the cardiac cycle have been studied, and we use special techniques to describe these various changes. The waveform of normal right atrial contraction is shown here. It consists of our two components, the A wave and the V wave. The A wave is identified as the next wave right after the QRS. It has an X descent. The next wave occurring in diastole is the V wave, and it has a Y descent. And the reason you see these normal waveforms is because different pathologic conditions and different disease states will alter these waves, and we can make those diagnoses based on waveform analysis. When we look at the pulmonary capillary wedge pressure, that's the pressure reflecting the filling in the left atrium, and left atrial pressure actually reflects ventricular pressure in diastole. So here is the tracing of a wedge pressure superimposed on left ventricular pressure. The A wave of the left atrium is shown here, represented by the wedge pressure, and its V wave shown here. Interesting for the wedge pressure, because it is delayed through the pulmonary capillaries, there is a time delay of 40 to 140 millisecond delay in the peak transmission of pressure. We'll see later that left atrial pressure actually occurs earlier than wedge pressure. But this is the normal waveforms we see for left and right atrial pressure. During inspiration, the chest expands and pressure inside the chest becomes negative. Negative pressure is transmitted normally to the right atrium, and right atrial pressure falls during inspiration. This is a normal requirement. However, in patients with congestive heart failure, patients with constrictive pericardial disease, or even in tamponade at times, they cannot reduce their pressure during inspiration because of forces acting to maintain pressure in the right atrium, and a failure to fall or rise in right atrial pressure during inspiration is considered highly abnormal, often given the name Kussmaul's sign, and it's characterized by exaggerated Y descents during inspiration. The normal relationship between the pulmonary capillary wedge pressure and left ventricular pressure is shown here. There is this time delay that we just discussed a moment ago in both the A wave and the V wave. And I point these out because, as we will see when mitral valve disease is present, this wedge pressure becomes altered, elevated, and a gradient for mitral valve disease develops across the diastolic period. Here are tracings which represent a left atrial pressure directly measured from a transeptal puncture with a mean pressure of 20 millimeters of mercury and a V wave up to 40. The A wave is 30 to 24, V wave of 40. As we pull back across the intra-atrial septum at this point, we see the right atrial pressure. So left atrial pressure is higher than right atrial pressure. V waves are often greater on the left side than the right side. And we'll get to see this relationship in a bit more detail. Big V waves represent a number of things: stiff left atrium, mitral regurgitation, perhaps VSD. In this case, it was due to a high compliance in a patient who had a stiff left ventricle. Among the most common pressure tracings we will see in the cardiac cath lab is that of aortic pressure and left ventricular pressure. Here is the measurement of left ventricular pressure in blue, the aortic pressure in green in a normal individual, measured with simultaneous high-fidelity micromanometer transducers to show you what the ideal pressure tracing should look like. Left ventricular pressure starts here at the A wave. Left ventricular end diastolic pressure occurs here at the end of the A wave, corresponding to the R wave on the electrocardiogram. Isovolumetric contraction occurs, the aortic valve opens, and this small gradient which is present, this 1 to 2 millimeter gradient, is a normal intrinsic gradient of impulse where the blood is ejected rapidly across the aortic valve. This is a normal finding. This is the anacrotic shoulder. Here's your dicrotic notch and the normal decay of aortic pressure. As the ventricular pressure relaxes, the lowest pressure is earliest, and then across diastole gradually fills as atrial emptying occurs. This is the normal filling with the lowest pressure early, followed by the A wave. Changes to this characteristic pattern indicate abnormal relaxation. Now, unfortunately, we don't get to use high-fidelity pressure measurements very often. We have to contend ourselves with fluid-filled systems, and we often measure pressure from the femoral artery using a 6 French sheath and another catheter, a pigtail catheter, one size smaller, and we use the side arm of the femoral sheath to represent femoral artery pressure, and we measure aortic pressure through the pigtail. So the first pressure up would be a pigtail pressure in the central aortic position. The second pressure up would be the pressure measured as it arrives at the femoral artery, and it often has an overshoot which has summation artifact. So femoral artery pressure is higher than aortic pressure, and it's due to the elastic recoil of the vascular system whose pressure waves summate and cause this resonant artifact. This is a normal relationship, and in some cases it becomes great. In young people it can become higher, in aortic insufficiency it can become higher, but you should look for this. When we put the pigtail catheter into the LV, we see this same systolic relationship shown here, but now we can see the diastolic waveform of the LV pressure, similar to that which we saw with the high-fidelity systems. And again, a normal appearing left ventricular tracing with lowest pressure early, diastasis, and then A-wave filling of the LV. Now, unfortunately, some patients don't have normal ventricles. Their LV pressure waves may appear unusual, and in fact, this is an abnormal pressure wave. Notice that the lowest pressure is not early, it's mid in a lot of these beats. This is an abnormal configuration of diastolic pressure, and it represents abnormal left ventricular pressure and abnormal left ventricular relaxation, characteristic of diastolic dysfunction. And indeed, that's exactly what this patient had. Now, in the cath lab, we use these pressures to tell us about problems that may develop. Here's a quick example of a patient before left ventriculography who had normal aortic pressure and normal left ventricular pressure, and then suddenly after ventriculography had hypotension. And we believe this hypotension is due to an adverse reaction to contrast because we see very low filling pressures, eliminating the possibility that this was tamponade, perforation, myocardial ischemia, or valve rupture. So this is a manifestation of vasodilatation due to contrast allergy. When we go to look at the aortic valve, we measure this with the difference across the LV and aortic pressure, and we do a catheter-based pullback. We pull the catheter from the ventricle back to the aorta, and the two pressure tracings then match, indicating the aortic valve is not producing any resistance to flow. We will see that pullback without two pressure transducers can make for a complicated interpretation, and I believe is an inaccurate method to assess the aortic valve. Here's that example. We pull a single catheter from the LV out the outflow tract and into the aorta, and we can ask the question, does this person have aortic stenosis? Well, on this beat, yes, yes, maybe, and yes. But how severe is the aortic stenosis? We can't rely on a single catheter pullback. I'm going to show you our matched pullbacks in just a second. Now, here is a clear example of a patient who has a valve gradient across the aorta. Here's the aortic pressure. Here's the higher LV pressure. This is aortic stenosis. Here is a aortic stenosis beat and a premature ventricular contraction. And in the subsequent beat, we see a PVC that has a large gradient, a large pulse pressure, and the same upslope as every other beat. In the post-PVC for aortic stenosis, waveforms are maintained, pulse pressure is maintained, and the gradient is bigger because the cardiac output is greater. This will not be the case when we get to hypertrophic myopathy. Now, if we're going to measure gradients across aortic valves, these are the techniques that we use from least accurate to most accurate. Single catheter LV aortic pullback, I just showed you. Left ventricular femoral artery sheath, common, not as accurate as a long sheath in the central aortic position, not as accurate as two pressure measurements using both femoral arteries, or a double lumen pigtail, or a transeptal approach, or even a guide wire pressure sensor in the ascending aorta with a catheter. And of course, if we had a multi-transducer micromanometer catheter, that would probably be our best measuring technique. I'm going to talk about advanced hemodynamics. We just covered some of our basic information. In this segment, you're going to see some unusual tracings, but of common problems that the cath lab should be familiar with. When we talk about advanced hemodynamic findings, we're going to start to get into problems related to causes of hypotension during cardiac catheterization, in which the etiology may be uncertain, but in which hemodynamics can help us determine what's causing this problem. I'm going to show you briefly some differences between aortic stenosis and hypertrophic obstructive cardiomyopathy hemodynamics. We are not going to spend much time talking about low gradient aortic stenosis, but good hemodynamics will provide an answer for that problem. We will discuss mitral regurgitation and stenosis, and it'll be important to employ these techniques when we talk about prosthetic valve dysfunction, constriction and restriction, tamponade, and cardiac shunts. Unfortunately, we're not going to cover coronary hemodynamics and lesion assessment today, although this is my favorite topic. Let's look at a few more hemodynamic tracings. Remember, in the basic hemodynamics section, we talked about normal right atrial and normal wedge pressures. I put them up here just to remind you, and then ask you, is this a normal right atrial pressure? And certainly it doesn't have the waveforms that we saw just a moment ago. Whenever confronted with a pressure waveform that you are uncertain about as to its cause or its manifestations, always look at three things. Check the cardiac rhythm in the electrocardiogram, check the scale on which the pressure is measured, and then make sure that the pressure waveform comes from the place that you think it's measured. In this case, the rhythm is a tachycardia. You see at least 2 QRS complexes in every 1 second. I can tell you now the scale is 0 to 40 millimeters mercury, and that this big V wave is occurring without any atrial A wave, and the mean pressure is 8. So this appears to be a right atrial pressure during some kind of tachycardia. Let's see what happens when that tachycardia breaks. Here is sinus rhythm at a rate of 60 beats per minute with restoration of what looks to be an A wave with a notch, a minimal V wave, and no regurgitant V waves of this tachycardia. This turned out to be ventricular tachycardia with marked tricuspid regurgitation, which when broken had normal right atrial pressure. Now, in aortic stenosis, this is the most common valvular lesion that we see in the cardiac cath lab in adults. Here is a normal aortic valve, normal, thin, beautiful leaflets, membranous. They come together in this tri-leaflet fashion with their cusp nicely coapting. They're almost translucent, no calcium buildup, and the ostium of the coronary arteries are tucked away in these coronary sinuses. Here, on the other hand, is a congenitally narrowed bicuspid aortic valve with thickened rolled back edges, a fused commissure, thick calcium deposits, and inability to open up very widely, and produces obstruction to left ventricular outflow. I think it's important to recognize that the opening is certainly not the point on a volcano in which many of us have imagined aortic stenosis looks like. It's really an elliptical orifice, which is very hard to calculate the true area. That's why we have to measure pressure and flow and give an estimate of valve area based on those numbers. Now, when we talk about the hemodynamics of aortic stenosis, I bring you back to the Wiggers diagram with a normal configuration. When the aortic valve is narrowed, left ventricular pressure has to increase markedly to push through the resistance of that aortic valve. And by having that aortic valve narrowed, aortic pressure has a different configuration and is not ejected at the same rate. And the difference between the aortic pressure and the left ventricular pressure is the left ventricular pressure gradient. And with that gradient, we can explain both the valve area and some of the physical findings associated with aortic stenosis. Based on this physiology, we know there will be a late peaking systolic murmur. A single S2 is common with severe valves because the leaflets don't coapt. And we see a slow pulse upstroke in the carotids. And it's explained on the basis of these hemodynamics. Now, we measure aortic valve gradients by using often a femoral artery pressure measured in the sheath and the left ventricular pressure measured through the pigtail catheter. But if we put up a second catheter and measure central aortic pressure here, we see the difference. This would be the femoral artery pressure in yellow, and the central aortic pressure area shown by this orange shaded area, and you know that femoral artery pressure contributes more to the gradient. So if we want to know which of these two pressures gives us the more accurate area, clearly it's the central pressure. But when we have the femoral pressure, we should not shift it because that would artificially make the valve area smaller than it really is. We see that the unaligned pressure gradient produces a valve area of 1.7. The unaltered femoral artery pressure produces a valve area of 1.01, but if we shift it back, we get this very large increase, underestimating the severity of disease with a valve area of 1.24. This work from Folland is well known, and if you have to do something, select the unshifted one or use a central aortic pressure. Now we have two gradients on two beats. We have a pressure gradient here that is of a certain size with LV pressure just under 200. We know this is a centrally measured pressure because there's no femoral artery delay. And we see a second beat with a larger gradient, considerably larger, and we see this aortic stenosis. So the question that's asked is, why is this gradient bigger than this gradient? And the answer is clearly, if we look at the rhythm strip, this is a junctional beat, this is an augmented P wave, a normal sinus beat. The atrial kick contributes more cardiac output, more gradient, and shows us this aortic stenosis better. So it's important to remember patients who have aortic stenosis often need their atrial kick to maintain a good cardiac output in critical aortic stenosis. Now we can measure pressure through valves using a pressure sensor guide wire, and here's an example of a pressure measured through a St. Jude bileaflet valve. The wire is very thin. This is a 14 thousandths pressure wire. If we compress the leaflets of the valve, we can still move the wire out. We get very excellent high fidelity tracings, so we can assess this bileaflet valve using a pressure wire if we needed to. And it's one technique that's been reported in the journals relating to cardiac catheterization. Now on our basic hemodynamics, or just a few moments ago, we talked about the findings in a post-PVC beat of the gradient related to aortic stenosis. Let's take a look at this one. Here is another tracing with an aortic LV gradient and a pulse pressure indicated by this big arrow. On the post-PVC beat, we see a very big gradient, but we see a smaller pulse pressure and a change in the waveform of the aortic pressure, and notice that the upslope of the aortic pressure is not delayed. So this pressure tracing and this response here is characteristic of hypertrophic obstructive cardiomyopathy. The pulse pressure gets narrow on the post-PVC beat. That's the Brockenbrough-Brunwald-Morrow sign. There is a spike and dome configuration to the aortic pressure, and there is this rapid preserved upstroke. All three features not present in the aortic stenosis post-PVC beat. Here is the pathology involved with hypertrophic obstructive cardiomyopathy. Very thick intraventricular septum, thick posterior wall. The mitral valve leaflet is pushed or pulled into the ventricular outflow tract to create the gradient. Mitral regurgitation exists, intracavitary gradient exists, and part of our treatment is to resect or ablate that part of the intraventricular septum in those patients who have obstructive cardiomyopathy. Here is another example. Here is aortic stenosis with the post-PVC beat showing delay upstroke, no change in configuration, wide pulse pressure, and the post-PVC hokum beat showing narrow pulse pressure, rapid upstroke, and the spike and dome configuration. I think it's easy to distinguish between these two conditions and will be part of the examination that our trainees go through. Now, mitral stenosis is characterized by a thickened mitral valve leaflet that has become inflamed, rolled back, very fibrous. Its thin, filmy nature is gone. It constricts and fuses at the commissures and forms a fish mouth appearance described by pathologists over a century ago. Why it's called a fish mouth appearance is a mystery, but it's still one of the common nomenclatures. When we look at the mitral valve, which is the valve between the left atrium and left ventricle, in mitral stenosis we see this thickened valve, calcified at times, a narrowed orifice, shortened, thickened chordae tendineae. Sometimes they're calcified, usually a small ventricle. And on echo, that's exactly what we see. Left atrium is here. The thickened mitral leaflets with a fixed small orifice are here. We may see calcification. And in certain morphologic valves, we can perform balloon commissurotomy to open up the mitral stenosis if it's clinically indicated. We're going to look at the hemodynamics of this now. So here is the normal left atrial, left ventricular pressure wave relationship. The A wave corresponds to the A wave of the ventricle, the V wave to the V left ventricular diastolic pressure wave across diastole, which is here, a very small gradient of no significance except to push blood from the left atrium into the LV. This is normal. Now, when we look at a patient with mitral stenosis, the left atrial pressure is higher at all times across diastole, that is from here to here, and this is the pressure gradient of the left atrium pushing the blood out of the left atrium into the ventricle through that narrowed valve. You see an A wave and a V wave and this pressure gradient. And this gradient, when calculated, tells us how severe the mitral stenosis is. Remember, this is the normal pulmonary capillary wedge pressure against LV. And now, when we look in a patient who we believe has mitral stenosis, when we see this pulmonary capillary wedge pressure, we have to ask, is this a real pressure tracing? Does the patient have mitral stenosis? Is this reliable wedge pressure? And how much of a gradient? Now, none of this can be answered if we don't have a good tracing, and this, I put to you, is not a good tracing. When we put the pulmonary capillary wedge pressure against the direct transeptal left atrial pressure, the mean values correspond nicely, but the phasic characteristics do not correspond very well at all. And here is, in the same patient, that left atrial pressure against LV pressure, and it's clear that the gradient exists. This person happens to be in sinus rhythm because we see nice presystolic accentuation, and we can calculate the gradient. And with this, we can then say, well, mitral valvuloplasty with a balloon, in-a-way balloon system is indicated, and in fact it was performed. Here's the in-a-way system before the balloon is inflated, distal inflation of the balloon, retraction into the mitral apparatus, beginning inflation, during inflation, final inflation, and now let's check the pressure again across that mitral valve. So here's the pressure, and we're looking again at the pulmonary capillary wedge pressure in the LV, and we have a little residual gradient. Well, if we didn't like the wedge pressure when we started, we're not going to like the wedge pressure when we finish, and in fact we don't. When we put the left atrial pressure back up against the LV, we see that the gradient is completely gone, and we have a very successful result that we would not have appreciated had we just used the wedge pressure alone. So good hemodynamics make for a good procedure. Now, we'll conclude here with this tracing: left ventricular pressure, left atrial pressure, and a big V wave, a giant V wave. And these giant V waves, in this case to 60 millimeters of mercury, indicate usually severe mitral regurgitation, but can also be present with ventricular septal defects or high noncompliance. But generally to this level, this is indicative of very severe mitral regurgitation. And mitral regurgitation is caused by myxomatous generation of the mitral valve. These pillowing leaflets can break and not coapt, or you can have acute papillary muscle rupture, which may occur during myocardial infarction. Hello, welcome to our section on hemodynamic calculations. I'm going to talk to us today about the various measurements we make in the cath lab to understand different physiologic parameters that are commonly used in the diagnosis of heart disease. These numbers are obtained in the cardiac catheterization lab and used to make clinical decisions. Let's start with cardiac output. Cardiac output is blood out of the heart measured in liters per minute. The normal value is 5 liters per minute in adults and can range from 4 to 6 or 7 depending on the clinical situation. The cardiac output is calculated by heart rate times stroke volume, and the stroke volume is the amount of blood ejected out of the heart with each heartbeat, roughly between 50 and 70 milliliters, and thus a 60-beat heart rate would calculate out to a cardiac output of about 4.2. This number, the cardiac output, can be varied by different sized people and can be measured and assessed across a number of different body types by indexing the cardiac output for body surface area. The cardiac index is the result of cardiac output divided by that body surface area and has a normal value of approximately 2.5 to 4 liters per minute per meter squared. This cardiac index decreases for advancing age, generally because body mass likewise decreases. To calculate cardiac output, we can use 3 different methods. We can use the angiographic method, we can use the Fick method, and the thermodilution method. All 3 of these can be measured in the cath lab, the most common of which is the thermodilution measured method using a Swan-Ganz pulmonary artery balloon-tipped flotation catheter. In brief, the angiographic method uses the X-ray diameter and size of the image of the diastolic left ventricular volume compared to the systolic volume. The difference is the stroke volume, and that number is calculated multiplying it times the heart rate to yield the cardiac output. The Fick method depends on the measurement of oxygen consumption and the pulmonary artery oxygen content versus the mixed venous oxygen content is determined. We'll go over each of these methods in a little more detail in the subsequent slides. The angiographic cardiac output is determined by the stroke volume from the angiogram. The stroke volume is measured as the end diastolic volume minus the end systolic volume, and the cardiac output is then calculated as heart rate times stroke volume. The limitation of this method is the requirement to use a reference size object to determine the absolute volume of the end diastolic image and the end systolic image. This has been a method that has not been used in the last few years, but has been a standard in the early days of cardiac catheterization. The Fick cardiac out method is generally the gold standard for determining cardiac output. It assumes there is no shunting across the heart, no mixing of blood between the 2 atria or ventricles that is abnormal, and it relies on the fact that pulmonary artery blood flow will equal systemic blood flow across the aortic valve. Cardiac output is then calculated as the patient's oxygen consumption divided by the arterial venous oxygen content difference. The measured uptake of oxygen from the air by the lungs is equal to the oxygen uptake from the lungs into the blood. The difference between the pulmonary artery saturation instead of the pulmonary venous saturation is required. Oxygen consumption can be measured in 2 methods, either directly using a polographic hood measurement or a paramagnetic method. These are rarely performed in today's cardiac cath lab. More commonly is the use of an estimation of the oxygen consumption by the formula oxygen consumption, that is VO2, is equal to 125 times the body surface area. The normal VO2 is 125 times 2, which equals 250 milliliters O2 per minute. The value of 2 was the body surface area for an average individual adult male. The Fick method requires the collection of samples using heparinized syringes, sometimes glass, and running the oxygen content of these samples through the content analyzer. Oxygen content is determined by oximetry, and it is reported as percent hemoglobin as a variable of the oxyhemoglobin in the blood. The oxygen is then equal to the hemoglobin in grams per deciliter times a correction factor of 1.36 times 10, and that yields the oxygen carrying capacity in milliliters of oxygen per liter of blood. In such a calculation, there may be errors introduced, and for this reason, cardiac output must be considered somewhat variable under certain circumstances. Errors that will interfere with accurate cardiac output are the following. It is assumed that the patient is in a steady state. That is, it's not a changing hemodynamic condition, unstable condition, fever, or tachycardia. If there are oxygen samples which are contaminated by air and not immediately analyzed, this may introduce error of the oxygen content measurement. It is also assumed that the oxygen consumption for the individual is 125 milliliters per meter squared, or as the person is very elderly, 110 milliliters per meter squared, but this indeed may not be true for all individuals under all circumstances. The FIC is most accurate for low cardiac output, more so than the thermodilution method, which we will talk about next. The thermodilution cardiac output method is the most commonly used in the cardiac cath lab. It is measured using a right heart catheterization, commonly a pulmonary artery balloon-tipped flotation catheter, also known as a Swan-Ganz catheter, and it uses a known temperature of the blood compared to the changing temperature which occurs as the blood carries a cold indicator of room temperature saline through that blood to the thermistor at the end of the catheter. The change in blood temperature in the pulmonary artery is measured, and this change in blood temperature over time is inversely proportionate to the blood flow through and across that segment of the artery. In this case, of course, the pulmonary artery, and we again assume that pulmonary artery blood flow and systemic blood flow is the same in the absence of any intracardiac shunt. The detected temperature change is relatively related to the cardiac output, and the change in indicator temperature over time is the marker of this change in cardiac output. The advantages of the indicator dilution method are that it does not require withdrawal of blood for oxygen sampling. There is no arterial puncture needed. This is performed with a right heart catheterization. The indicator is inert and inexpensive, that is, we use room temperature saline, and there is no recirculation, making the computer analysis of the primary time temperature curve simple. Again, with any method in the cath lab, we always have to be considerate of possible errors that we may introduce. For the thermodilution method, this means that our bolus of cold saline may not be accurately delivered to the pulmonary artery in patients who have severe tricuspid regurgitation and low cardiac output syndromes. In addition, pulmonary artery temperature changes as the cold injectate is injected as well. So changes in PA temperature are a result of the volume of injectate and may vary, and hence the cardiac output may vary depending on that bolus. In low flow conditions, low cardiac output may cause a warming of the bolus of cold injectate and thus produce a false value. There is, in addition, an empiric correction factor of 0.825, which may not be adequate for the derivation of the true injectate temperature. These correction factors are set on the equipment prior to the measurements. What's the method for measuring thermodilution cardiac output? How do we do this? Well, it's a fairly straightforward method. We use 5 or 10 cc's of cold saline, or we could use room temperature saline. We usually make the injection on 2 or 3 separate occasions and average the values. We inject the cold indicator solution into the proximal hub of the pulmonary artery catheter. This is the right atrial port. Now, the room temperature saline is considered cold relative to the 98-degree blood temperature of normal individuals. The next step is to identify the temperature change which detected at the thermistor tip, located now in the pulmonary artery, and the curve of this temperature change can be used to calculate the amount of blood that flows across the thermistor. This is plotted in a curve, and the computer generates the cardiac output from this injection. The amount of saline injected each time should be the same, and it should be injected as rapidly as a bolus as possible. And this should then yield several values which can be averaged together to produce the final cardiac output measurement. The shunt run. The purpose of a shunt run is to see if there is a step up in the blood oxygen content or saturation that exceeds the normal variability that might be found in the person's heart. The shunt run is used to detect a cardiac shunt at the atrial or ventricular level and is used to identify these pathologic conditions in those individuals suspected of having atrial septal defects or ventricular septal defects. The criteria of oxygen step-up are listed here, and for each level of the shunt occurring at either the atrial level, ventricular level, or great vessel level, the significant step-up difference in oxygen saturation is shown as greater than 7%, greater than 5%, and again for great vessel, greater than 5% difference between the proximal chambers and the distal chambers. It's important to remember that shunts occurring at the atrial level, the proximal chambers sampled are the vena cava. For shunts at the ventricular level, the proximal chamber sampled is the atria. And for the great vessels, the proximal chambers sampled are the ventricles and ventricular outflows. The saturation run is performed by collecting samples from each of the multiple sites from the superior and inferior vena cava all the way through the right heart, the tricuspid valve, the right ventricle, and up into the pulmonary arteries, the left and right and main pulmonary arteries. We also collect blood from the aorta, occasionally from the left ventricle, and if possible from the pulmonary veins if these sites are available. That is, if we list those sites from which we wish to draw blood, beginning in the inferior vena cava, we do low inferior vena cava, high inferior vena cava just below the right atrium. We do the superior vena cava, low and high. Then we would collect blood from the high, mid, and low right atrium, blood at the tricuspid valve on both the atrial side, then on the ventricular side. We would collect blood in the right ventricle at the apex and in the outflow tract. Moving to the pulmonary artery, we would collect main pulmonary artery blood flow, left and right pulmonary artery blood flow. And this would give us a complete site map of the shunt possibility in the patient with a cardiac shunt. The calculation of pulmonary blood flow, QP, is equal to oxygen consumption divided by pulmonary vein oxygen content minus pulmonary artery oxygen content. The pulmonary vein oxygen content will be assumed to be 95%. If there is a right to left shunt, then we will use a pulmonary vein oxygen saturation of 98%. For systemic blood flow, QS is calculated as oxygen consumption divided by systemic arterial oxygen content minus mixed venous oxygen content. Mixed venous oxygen content is measured before the level of the shunt, that is, at the chamber below the shunt. For an atrial shunt, mixed venous oxygen content is equal to 3 times the superior vena cava sat plus 1 time the inferior vena cava sat. These summed and divided by 4 will give us the mean mixed venous oxygen content. An example of this is shown on the next slide. The data we obtain at cardiac catheterization tells us that the hemoglobin is 12 grams, oxygen consumption 250 milliliters per minute, and the saturation run shows the arterial sat 95, SVC 68, mid RA 86, low RA 69, PA sat 84, and IVC sat 66. If we examine these sat numbers, we can see that the greatest step up occurs between the vena cava and low right atrium and the mid right atrium and ultimately the pulmonary artery as well. So from these saturation data, we can assume there is a step up in oxygen occurring somewhere in the right atrium, or these data are consistent with an atrial septal defect. Now, how can we use these in the calculations of our shunt value? Well, listed on the following slide, we see that the arterial oxygen content calculation yields a value of 155 milliliters. The mixed venous oxygen content using the 3 SVC and the IVC data show that the mixed venous is 110 milliliters, and thus the pulmonary artery oxygen content calculated in a similar manner from the saturations yields a value of 137, and the pulmonary vein content now shows us that the saturation value is 150 milliliters as its content. Thus, plugging these values into the formulas we mentioned above, systemic flow QS is calculated at 5.55 liters per minute. The pulmonary artery blood flow, again using the formula that we just described, yields a calculation of 13.89 liters per minute, and thus the shunt, the pulmonary flow divided by the systemic flow, QP, divided by QS, is now equal to 2.5, a substantial shunt. Critical values are generally greater than 1.5. Now, on the next slide, we'll see what happens. Sometimes shunts are of such a size that they shunt blood in both directions. That is, they shunt it left to right, and then at another point in the cardiac cycle, it shifts back to a shunt right to left. And to calculate bidirectional shunts, we need to assess the quantity called effective blood flow. So the effective blood flow is the net yield of the values taken both from left to right minus the effective blood flow and right to left minus the effective blood flow. And these formulas are again shown below. So the left to right shunt is equal to the pulmonary blood flow minus the total effective blood flow, and the right to left shunt is the systemic flow minus the blood flow going over to the left. The errors in the calculation of shunt flow, again, are similar to those seen for the calculation of cardiac output using the Fick method. That is, we require the patient to be in a steady state, and the measurement of oxygen saturation lacks sensitivity and is prone to missing small amounts of shunting. Probably the most important area of hemodynamic calculations is that of computing valve areas. These measurements are made from the pressures obtained across the valves and coupled with the cardiac output values to yield the millimeter square valve area that is reported for both mitral and aortic valves. Let's start with the Gorlin formula. The Gorlin formula calculates valve area using cardiac output, and this value is reported for either the systolic ejection period for aortic valves or for the diastolic filling period for mitral valves. This fraction of the cardiac output for the cardiac cycle in which the gradient is generated is multiplied times the heart rate. The cardiac output for the filling period, therefore, is divided by the square root of the mean valve gradient measured from the pressure waves and multiplied by a constant. And these constants are different for the two different valves, 37.7 for the mitral valve and 44.3 for the aortic valve. For aortic stenosis, it's important to appreciate where the systolic ejection period begins and ends. On this graphic, the systolic ejection period is initiated at the R wave and ends at the dicrotic notch. You can see on the beat number 2, which has a gray shaded area for the aortic stenosis gradient, the vertical markers delineate the systolic ejection period, which in this case is 4.1 centimeters of paper, recording this at 100 centimeters per second of paper speed. The diastolic filling period is denoted by the crossover point of left atrial pressure and left ventricular pressure. In this graphic, you can see the shaded gray area representing the mitral stenosis gradient. The tracings labeled left atrium and left ventricle are shown there. The crossover point occurs at the peak of the V wave and again at the end of the A wave. And the diastolic filling period would then be demarcated by these 2 points. Finally, the Hockey formula. This method is a simplified approach to calculating valve area. It is most useful for aortic valve area, but has been applied to mitral valve area as well. It is accurate when compared to the Gorlin formula for heart rates between 60 and 100 beats per minute. To use the Hockey formula, simply compute cardiac output divided by the square root of the peak-to-peak gradient. Femoral access is the most commonly approached access site for cardiac catheterization in the United States. Outside the United States, radial access has now emerged as a predominant route. The reasons for the emergence of radial access often are to avoid the complications of femoral artery access. Listed on this slide are the common complications which result in vascular access producing the greatest morbidity and risk of the procedure. These complications include hematoma, AV fistula, pseudoaneurysm, infection, retroperitoneal hematoma, vessel thrombosis, and nerve damage. These complications vary by the type of procedure, whether diagnostic or interventional, and can be a great problem for both the operator and the patient. Risk factors for femoral artery complications include female gender, obesity, low body weight, hypertension, intense and over anticoagulation, including the use of GP2B3A blockers and thrombolytic agents. Femoral access begins with an understanding of the anatomy. On the left side of this diagram shows the femur with the overlying artery and vein of the leg. From the lateral to the medial aspect, there is the nerve, artery, and vein. In that order, it's easy to remember that if we want to access the vein, we should go medial to the pulse, and we want to avoid the artery being, again, on the center line of the femoral artery. The common femoral artery is defined on its lower border by the bifurcation of the superficial and profundal artery, and on the upper border by the lower curve of the internal epigastric artery. The goal of the operator is to enter the common femoral artery, which often spans the midpoint of the femoral head. The iliac crest is the high point. The symphysis pubis is the other point. The line 1 centimeter below that meeting point is the inguinal crease, and Dr. Suh is going to palpate for the artery. And when he feels it, he's going to take a marker and mark where the femoral pulse is, and we'll be able to then gauge if we're high or low for the femoral stick. So let's take a quick fluoro image. Marker is in a good position, so we know that the entry point here is correct for the femoral crease. A superficial skin bleb so the needle doesn't hurt. Then he'll go down alongside the artery on the medial aspect and along that lateral aspect and deliver about 10 to 15 cc's of the lidocaine 1% mix. After that, we'll be using the typical Seldinger needle. And as the worthy assistant, I'm going to introduce the guide wire, or hand him the guide wire when it comes time. Okay, here's your wire. So we have access to the artery, and if you just keep your images here, go ahead, Will. No, wait, before you go, let's make a little skin nick. This is customary if we want to think about a closure device at the end of our procedure, which we are thinking about right now. Okay, Will is going to press with the last 3 fingers and pinch with the first 2 of the left hand. Pull the needle off. His assistant or himself, he could introduce the sheath over the guide wire, and then with a rotary motion, he's going to introduce the sheath into the vessel. Okay, it's important to make sure that when you're done, you flush the sheath and take the sharps off the field. So that's what we're doing. Following sheath insertion, femoral angiography can be performed to identify the correct placement of the sheath. This is important either at the beginning or end of a diagnostic before proceeding to PCI, since a high puncture above the internal epigastric artery may cause significant retroperitoneal hematoma. In this case, closure of the femoral artery may be elected, and deferment of the procedure until another time if it is easy to do so. The angiogram shown here shows placement of the sheath in the correct location. The subsequent important aspects of both RAO and lateral views of the femoral artery demonstrate that in the RAO projection, separation of the profunda and superficial bifurcation will permit the operator to identify the fact that the puncture site is indeed away from this bifurcation. And in the lateral view, it's easy to appreciate why the location in the common femoral head has been selected, since the head of the femur acts as an anvil against which compression of the femoral artery can occur easily. A high stick would be compressed, but not against the force of the femoral head, and thus retroperitoneal bleeding is more common and likely. Femoral artery access can be complicated by dissection and femoral artery occlusion, as shown in this particular slide, where an injection of contrast does not move through the artery slowly. On the subsequent image, a dissection can be seen with the femoral artery having a flap of tissue, and dissection again holding the potential for occlusion or thrombosis. In the subsequent section, we're going to talk about hemostasis. There are many methods to hemostasis, using both manual and assisted manual compression. In this slide, we see manual compression by the operator's hand, a safeguard pressure system, a hemostatic patch, a compression tool which pushes down with a clamp-like C-arm, the Radistop, or now St. Jude Medical compression system, which inflates a pressure bubble over the puncture site, and finally a boomerang device, which is a temporary tamponade method of femoral artery occlusion. The four major mechanisms of vascular closure devices to obtain hemostasis in the cath lab include, from left to right, the stitch method using sutures implanted in the vessel, a pull and tamponade method using a collagen plug within the vessel and collagen tamped down on top of it, a click method employing sutures delivered to the surface of the vessel, and another pullback type of temporary puncture tamponade device called the boomerang. Patients who may benefit from a vascular closure devices are those who are most likely to have complications related to femoral access. These include obese patients, those with hypertension, the elderly, female gender, patients who cannot lie on their back for reasons of back injury or back pain, patients with aortic insufficiency, those who have undergone prior arterial puncture are at risk for bleeding through scar tissue that won't close, and those with advanced peripheral vascular atherosclerosis may not benefit by having vascular access in the femoral approach, but if they do, a closure device may be required. Other patients who have coagulopathy and those on anticoagulants or antiplatelet agents require the benefit of closure devices to reduce the likelihood of bleeding. Caution should be maintained, and in this same group of patients, radial artery access should be considered. The use of vascular access closure devices, while highly successful, is often associated, on occasion, with complications related to the specific type of vascular closure device used. In this example, we see on the left a filling defect from a collagen vascular plug inside the artery. In the middle, we see scar tissue and swelling used from the clip technique, and on the right, a infected hematoma, which occurred in a person who had a suture-mediated vascular closure device. Hello again. In this segment of our video, I'm going to talk to you about coronary angiography. I just want to talk a moment, though, about orientation so that we have a framework in which to reference ourselves. So if we think of the heart as the size of my fist and the coronary arteries as surrounding my fist, with the index and middle finger of my left hand here being the LAD and the circumflex, and the thumb being the right coronary artery, we can show all the projections that we're going to look at on the screen in very concrete fashion. So if the viewer there is the X-ray camera, the heart sits sort of in an anterior-posterior AP projection. As I rotate my left shoulder forward, or what we call left anterior oblique, the LAD rotates out toward the right side of the screen, and the circumflex is on the left side. And then if I move the camera, you're the camera, toward the cranial position, the arteries tip downward. So the left main comes out in the middle, LAD along the right side here, with septals and diagonals, and the circumflex and circummarginals run in this direction. Now let's go back to our unangulated view, go back to AP, and now let's rotate with the right shoulder forward, or right anterior oblique, and you see that the arteries cross over, and that the LAD now runs on the left margin of the heart, and the circumflex runs down in the atrioventricular groove. And if we tip the heart cranial, then the circumflex comes upward and is foreshortened, but the diagonals pop upward. And if we go caudal, then the circumflex falls downward, and we can see the circumflex well, and the diagonals become hidden. Okay, let's go back to 0 and back to neutral. And now let's look at the right coronary artery. This is, my thumb is the right. It runs outward in this first projection down the wrist, and the posterior descending comes out toward you. If we rotate now left anterior oblique, that posterior descending is directly in line with the camera. And if we go cranial, it tips the posterior descending artery downward. Now we'll go back to 0, and I'll rotate my right shoulder anterior oblique. And you see the right coronary artery as it comes down along the wrist, and down the bottom becomes the posterior descending. Now we're going to take all of these views and we're going to look at them here on the angiograms. So now we have the left coronary injection in the LAO projection with the LAD coming down, septals going to the left, and diagonals coming to the right. This is the left main. This is the overlap with the circ, and the circumflex comes out and makes the tightest curve generally on the margin. And then as the margin continues, these are the circumflex marginal branches. Let's take a look at that in motion. And here you can see how everything moves. Now, if we take the left anterior oblique view and we swing it all the way over to the right, we have this view, which is the right anterior oblique, and this is cranially angulated. So I'm going to stop it again. The circumflex now is tipped upward. Here's the circumflex. The LAD comes out and along the edge of the heart, and you can see septals coming off the LAD, and you can also see diagonals in the background. So the best views to view the LAD artery are the two cranial views. You can see the left main here as well, and the other features of the circumflex are obscured. Now let's tip the camera down to the caudal position, and we'll go to the next set of images. So this now is the LAO with caudal angulation. Best to see the left main and proximal portions of the circumflex, which is here. The LAD is coming up toward the camera and down. So it's very foreshortened and not well visualized in this LAO caudal view. And if we swing from LAO caudal to RAO caudal, we see this image here. This is the left main. Circumflex now is tipped downward, and we can see the circumflex and a big marginal branch coming off proximal in the circumflex. The LAD diagonals are overlapped with the LAD, and the septals coming off the LAD define its course. Let's take another look. The atrioventricular groove is back here where the circumflex runs, and in this individual the circumflex is small and does not supply the posterior descending aspect of the heart, nor does it supply the AV nodal artery. So this would be considered a circumflex non-dominant circulation. Okay, now after we shot the views of the left coronary artery, we took the catheter out, went to the right, and shot the right coronary artery. And here is the right coronary artery. Again, left anterior oblique view with the posterior descending coming out toward you. You can very nicely see that the right coronary artery, after the conus branch and the AV nodal branch, has a very significant stenosis. It should be as smooth and big as the rest of the artery. This is an RV marginal branch, another marginal branch, and then at the crux of the heart, the AV nodal branch goes up and the posterior lateral branches come out. Let's take a look at this, and I think it's very nicely depicted that the stenosis is worse when the vessel is moving than any still frame we can get, and that the AV nodal branch and posterior descending tell us this is the dominant vessel in the heart. Now swing from left anterior oblique to right anterior oblique, and again the posterior descending now is horizontal to the film, perpendicular to the axis of the film, and you can see the different vessels again. So let's just look at them. So the first branch coming up and going anterior toward the pulmonary artery is the conus branch. The SA nodal branch would be a branch that goes posterior. Here's our stenosis in its second view, and it's tight in this view, and it's also tight in the other view. RV marginal branch, posterior descending, AV nodal branch up this way. So at the conclusion of coronary angiography, we performed ventriculography. And as you can see, we inserted the pigtail catheter into the ventricular cavity and measured pressure, which we'll talk about in the next segment. And after we measured our pressure, we injected X-ray contrast under high pressure with our automatic injector system. And we were able to fill the ventricle with our power injector with very little contrast. In this case, this was only 21 cc's of contrast. The normal range for ventriculography is anywhere from 20 to 50 cc's injected at a rate of between 10 and 15 cc's per second. The walls of the ventriculogram are all moving, and let's look at the 5 walls of the ventriculogram in this right anterior oblique projection. So in diastole, with the heart fully expanded, we have the anterior basal, anterior, anterior apical, inferior basal. The plane of the mitral valve is here, the plane of the aortic valve is here. And you can nicely see that every segment of the walls of this man's heart are squeezing and contracting to the center normally. The difference between area of diastole and area of systole is the ejection fraction, and above a 50% change in that area is normal. Now, because we have a biplane system, we get a bonus ventriculogram in the left anterior oblique with some cranial angulation. And in this image, the lateral wall is the high basal part, true lateral, apical part, and now we look at the septum near the apex and the septum near the base. This is the mitral valve plane, and this is the left atrium up here. This is the aortic valve plane, and then on the other side of this structure is the right ventricle. And so we look for things concerning those structures in some alternate views other than the right anterior oblique projection. Let's look again at the motion as in the left anterior oblique with cranial angulation. And it's the best view for looking at the lateral wall, which is not visible on the right anterior oblique images. Valvular regurgitation. The quantitation of valvular regurgitation by angiography is semi-quantitative. It comes in 4 grades. These grades are described as contrast filling the chamber to different degrees, from 1+ to 4+. 1+ is a small amount of contrast in the chamber without outlining the chamber or persisting. 4+ is contrast filling the chamber to an equal density of the ejecting chamber and persisting for 1 to 2 beats after ejection. Here's an example of regurgitation. An injection of contrast into the aorta fills backward into the left ventricle and produces an image of left ventricular activity. The left ventricle is opacified to a lesser degree than initially would be had the contrast been injected directly into the left ventricle. Aortography can identify both the widening of the aorta in the ascending portion as well as the separation of leaflets with regurgitation into the left ventricle. Thrombus is detected angiographically and graded by the amount of stasis achieved when contrast is moved through the vessel. The grades of thrombus range from 0 to 6, with the angiographic definition being that of contrast visible on 3 sides of a lucency. The amount and persistence of dye staining within that region characterizes the severity of the thrombotic occlusion. TIMI grade flow was derived from the study of thrombolysis in myocardial infarction back in the early 1980s. There are 4 grades of TIMI flow, ranging from 0 or no antegrade flow beyond the point of occlusion to TIMI grade 3 flow, which is full and brisk flow of contrast matching that of uninvolved vessels. The 2 grades in between of TIMI grade 1 and TIMI grade 2 are generally easy to separate. 0 to 1 is commonly grouped together, and grade 3 and grade 2 are grouped separately. These grades of TIMI flow are also associated with prognostic information in large myocardial infarction studies. Examples of TIMI grade flow can be seen on the following angiograms, in which the vessel opacification is evidently slow and the ST segment elevation myocardial infarction due to the occlusion responding to therapy. Collateral flow on angiograms have been first described by Rentrup, and the establishment of a collateral grade by angiography also put forth for use in the myocardial infarction trials. Collaterals range from 0 to 3 grading, with 0 being no collaterals and 3 being full epicardial large visible collaterals. Partial filling of the epicardial vessel via collaterals is noted for grade 2, and a filling of the side branches in the occluded epicardial vessel without the contralateral epicardial vessel is seen for grade 1. An example of angiographic collaterals is evident here for occlusion of the left anterior descending artery, and on injection of the right coronary artery, contrast can be seen filling the right, and contrast fills branches up through the septum to the left anterior descending coronary artery. In a patient with an occluded right coronary artery, contrast can be seen injected into the left coronary artery, traversing the septals and filling the distal right coronary artery. Angiographic identification of anomalous coronary arteries can be difficult, misleading, and often produce confusing results. Anterior takeoff of the right coronary artery is the most common coronary anomaly we see. Often an Amplatz catheter or an anterior takeoff is needed to identify this. Coronary artery fistula are considered anomalies of a benign nature. In this example, a small branch leaves the left coronary artery and moves over to the pulmonary artery, where contrast can be seen entering that vessel. The anomalous takeoff of the circumflex coronary artery from a right coronary artery cusp traverses the aorta in a retroaortic fashion and produces this characteristic finding. The identification of a long left main segment in which one suspects that the circumflex may be occluded is a clue to search for the anomalous circumflex coronary artery from the right coronary cusp. This retroaortic course in the right anterior oblique projection produces a end-on view of the coronary artery with a dot where the coronary artery turns over on itself with this double density. This is always a retroaortic position and of no clinical significance. Coronary arteries now are best seen by CTA, in which imaging of both the coronary arteries and the associated structures can be well identified, leaving little doubt for the true course and pathway of the anomalous coronary artery. The most dangerous and potentially lethal coronary anomaly is that of the left main coronary artery arising from the right sinus of Valsalva and traversing between the aorta and the pulmonary artery. In this example, in a young individual, the left main coronary artery runs from the right upward, forming an anterior dot in front of the aorta and moves forward down the LV. This anomaly can be appreciated by CTA and is often associated with an oval or slit-like orifice where the artery originates in the wall of the aorta. It can be managed either surgically or in some rare individuals with a stent. The next anomaly is that of an anomalous left main coronary artery running in an intraseptal course, forming an inferior loop or inferior eye in which the left main is beneath the level of the pulmonary and aortic valves. Current approaches to high-risk percutaneous coronary intervention. High-risk coronary intervention is a common and difficult problem to manage in the cardiac catheterization laboratory. Features that engender high risk include the specifics for the patient, their clinical presentations, and their anatomic findings. The risks for high-risk debilitation and problems include those factors which lead to clinical decompensation, heart failure, pulmonary edema, hypotension, shock, arrhythmia, myocardial infarction, need for emergent CABG, or even death. The predictors of high-risk catheterization have been derived from experiences reported by the Mayo Clinic and the NHLBI. These are inclusive of patient characteristics, usually those of the elderly, those with congestive heart failure, low ejection fraction, chronic kidney disease, and shock. There are specific lesion characteristics associated with high-risk events. These include the presence of thrombus, multivessel coronary artery disease, severe and total occlusions. And from this data, models have been built to predict the mortality and complications related to high-risk PCI. In the determination of high-risk individuals, one of the most important factors is that of ejection fraction. An ejection fraction of less than 40% had an increased in-hospital rate of death, MI, and CABG, and these rates persisted at 1 year. Lesion characteristics of high-risk PCI are usually those of complex lesions. That is, these include lesions showing evidence of thrombus, calcification, or bifurcations. In addition, osteolocations and chronic total occlusions often are associated with poor outcomes. These classification of lesion types have been summarized and are presented in an ACC-AHA classification scheme depicting lesions as type A, B, or C, and the characteristics of these different types of lesions are well described and associated with outcomes indicating increasing risk for the increasing severity of lesion complexity. In order to support the high-risk patient in the pre-shock state or in the shock state, we are obliged to use cardiac support devices. And there are really 4 types of devices available to us. These include intra-aortic balloon pumping, the tandem heart with an external circulatory pump, the Impella, which is a catheter-derived pump from the ventricle to the aorta, and cardiopulmonary support as would be used in bypass surgery. Let's look at the intra-aortic balloon pump. This was first used in 1968, and its indications for use have been relatively unchanged over these many years. The indications would include insertion for patients who have refractory angina, severe hemodynamic compromise, post-cardiotomy pump failure, and the support of the high-risk PCI patient. How does the intra-aortic balloon pump work? The balloon pump is positioned in the aorta and inflates rapidly in early diastole. It inflates to generate a diastolic pressure wave, pushing blood back toward the heart and into the coronary arteries, and also up to the head and down to the feet. This increase in coronary perfusion pressure and coronary blood flow is one mechanism by which myocardial ischemia can be abated. It should be noted that it is difficult for blood flow to cross severe stenosis, so the benefit in coronary perfusion really occurs through either improved collateral support or blood flow through intermediately severe lesions permitting blood flow to occur. The next phase of intra-aortic balloon pumping is the rapid deflation of the balloon at end diastole just before systolic ejection, which reduces the afterload against which the heart must pump. This is determined by a reduced aortic systolic pressure at the initiation of ejection and can be appreciated as a lower ventricular afterload, making the heart more efficient and reducing myocardial oxygen demand. The decreased myocardial oxygen demand from lower systolic wall tension and increased coronary perfusion pressure improves both the supply and demand sides of the myocardial ischemia balance. Cardiac output is only modestly increased, about 0.5 liter per minute, due to improved myocardial contractility from the improved coronary perfusion and reduced afterload. The advantages and disadvantages of intra-aortic balloon pumping are shown to us on this slide. In favor of intra-aortic balloon pumping, it is a familiar tool. It can be inserted rapidly. It has a relatively low complication rate, and it can be left in place for a prolonged period of time. Against the use of intra-aortic balloon pump is the fact that it is only minimally supportive of cardiac output. It requires a minimal level of cardiac function to even continue, and it often functions best when the rhythm is stable. Now, we can use other kinds of support devices, And one of those recently introduced in the last several years is that of the tandem heart. This is a percutaneously inserted set of tubes to then connect the arterial and venous flow together and unload the filling of blood from the left atrium into the left ventricle. This is performed by performing a transseptal puncture from the femoral vein to the left atrium and inserting a 20 French cannula. This drainage of the left atrium out the femoral vein access site is connected to a centripetal pump, and the blood is then pushed back into the femoral artery through a 14 French cannula, thus bypassing the left ventricle and performing femoral perfusion. This technique directly unloads the left ventricle, decreasing cardiac filling pressures, cardiac workload, and myocardial oxygen demand. However, it is relatively contraindicated in right ventricular failure. Now, the advantages of the tandem heart compared to the intra-aortic balloon pump are several. The tandem heart has a marked increase in cardiac index, mean arterial pressure, and a substantial decrease in pulmonary capillary wedge pressure. However, these improvements occur at the cost of increased complications of bleeding and potential limb ischemia since the cannula are so large. There is no reported benefit in mortality for the use of the tandem heart in our patients. It is a clinical decision whether to employ this in these critically ill individuals. The tandem heart has, again, advantages and disadvantages, which are listed here. In favor of the tandem heart is that it provides near normal level of cardiac support. It can be inserted percutaneously, and it is available for prolonged usage. The disadvantages of the tandem heart are that it is contraindicated in RV failure. It does require the performance of a transseptal puncture, and with this, the risk of tamponade in an already compromised patient. It can be difficult to place under emergent circumstances, and the large cannula are associated with increased vascular complication rates. Now, we continue to seek for improved methods for cardiac support in the high-risk patient. That brings us to the use of the most recently introduced support tool, and that is of the Impella support catheter. The Impella 2.5 is a minimally invasive catheter-based left ventricular cardiac assist device designed to directly unload the left ventricle. It reduces myocardial workload and oxygen consumption. It increases cardiac output and coronary end organ perfusion. The Impella pump can provide up to 2.5 liters per minute of flow, but cannot be used in patients who have aortic stenosis, LV thrombus, or RV failure. It is ideally designed to be used in high-risk PCI patients with left ventricular dysfunction or those having acute myocardial infarction. The Impella 2.5 system is shown here with its sheath and positioning unit. It has a pressure measurement in the pump plug. The connector for pressure bag and perfusion is also indicated, and there is a bacterial filter, air trap, and pressure reservoir at the end of the catheter. The catheter has 1 centimeter markers for positioning the motor drive across the aortic valve. On closer look at the motor drive segment of this catheter, we see that the very tip is formed into a 6 French pigtail catheter. There is a blood inlet cage through which the blood enters the cannula and passes the blood outlet cage as it is driven by a motor which draws the blood from the left ventricle, ejecting it into the aorta. The hemodynamics of the system are monitored continuously through a pressure lumen at the end of the input cannula. The reported coronary flow augmentation in acute animal models is shown here, and the comparison to intra-aortic balloon pumping with that of Impella shows that blood flow in the coronaries can increase from 53 to 69 milliliters per minute, a substantial increase compared to balloon pumping. The hemodynamic benefits of the Impella support catheter are diagrammed on this slide. The Impella decreases end diastolic volume and end diastolic pressure. This results in decreased oxygen demand, and through decreased wall stress improves oxygen supply through improving coronary perfusion. The increase in aortic pressure likewise drives coronary perfusion, increases coronary flow, and improves cardiac power output. A comparison of hemodynamics, especially the cardiac output with the Impella off as compared to the Impella on, show that cardiac output can increase from 6 to 7.4 liters per minute, and with left ventricular unloading, maintain the native cardiac output at around 5 liters per minute. The perfusion pressure waveform of coronary flow, shown on the next slide, demonstrates that in comparison to intra-aortic balloon pumping, the Impella provides a higher and more sustained perfusion head as compared to that of intra-aortic balloon pumping. Coronary blood flow velocity has been measured during Impella 2.5 support, showing that at the different steps of perfusion generated by the Impella, steps P1, 3, 6, and 9, coronary blood flow velocity correspondingly increases from 61 to 67 and ultimately up to 72 centimeters per second. The hemodynamics of the Impella then can be diagrammed for pressure volume loops and the improvement thereof. On the next slide, the pressure volume loop at baseline and with the unloaded ventricle of the Impella shows a left and downward shift of the end diastolic pressure curve, an improvement in the width and stroke volume of the improved ventricular function cycle, and a move toward improvement in perfusion and output. The PROTECT 1 trial using the Impella 2.5 device involved 20 patients at 8 centers. These were high-risk PCI individuals with ejection fractions of less than 35%. They either had unprotected left main stenoses or last available conduit supplying the myocardium. The PROTECT 1 trial then demonstrated freedom from hemodynamic compromise with mean arterial pressure maintained above 60 millimeters of mercury for more than 10 minutes, occurred in all 20 patients, and that secondary endpoints of freedom from ventricular fibrillation and freedom from VT requiring cardioversion were also conferred on all 20 patients. Angiographic success was performed in 19 of these 20. The 30-day major adverse cardiac event rates demonstrated significant reductions in death and MI occurring at about 10%, zero target lesion revascularization and emergency CABG requirements, no strokes, and major adverse cardiac events were occurred in about 20% of individuals, a significant number from historical controls. Again, some advantages and disadvantages identified with the use of the Impella 2.5 catheter. The advantages of this catheter include the rapid initiation through catheter technique that is familiar to all operators. The familiarity of deployment of a pigtail in the left ventricle is quite easy in general. This was a smaller diameter device than that of the tandem heart, but considerably larger than that of the intra-aortic balloon pump. And it could be considered for somewhat prolonged use in these individuals. The disadvantages of the Impella also indicated that it was not complete support, as would be identified for the tandem or CPS support devices, and it was also contraindicated in right ventricular failure and aortic stenosis. This portion of the video is designed to demonstrate the quick setup of the Impella 2.5 catheter and the setup of the Impella 2.5 circulatory support system. This does not replace the instructions for use manual. First, the components of the Impella Quick Setup System. The Quick Setup Kit for the Impella 2.5 consists of the Impella 2.5 Quick Setup Guide, the pressure bag, integrated infusion tubing, which includes the B-Braun IV tubing, CM set, and placement signal flush. The Impella Pump Kit includes Combitron's monitoring kit or CM set, a 0.018-inch French guide wire, Braun IV tubing, and the Impella 2.5 catheter. In addition, you will need 20% dextrose solution and a diagnostic catheter of your choice without side holes that will be used to cross the aortic valve. Step 1. Flush. Turn the Impella console on. Place the D20 in the pressure bag. Open the Impella pump kit, including the blue cable and the quick setup kit, onto the sterile field. The sterile person will hand off the spike end of the quick setup kit to the non-sterile person, and they spike the dextrose bag and attach the pressure transducer to the side of the console. Make sure the red button on the pressure bag indicator is depressed. Pump up the bag until 400 millimeters of mercury appears in the red zone of the pressure indicator. Flush the tubing and close the roller clamp. Step number 2, connect. Person in the sterile field connects the gray end of the blue cable to the Impella catheter and snaps on the sidearm. The sterile person hands off the opposite end or the blue end of the blue cable to the non-sterile person, who then connects it to the right side of the console. Once the console recognizes the Impella is connected, the console display will instruct the user to connect the gray cable. The user will connect the yellow end of the gray cable to the left side of the console and the other end to the purge pressure transducer. Once the gray cable is connected, the console goes to the second screen, which will say, flush purge line and connect the reservoir filter on the catheter. Flush the purge lumen until the purge pressure exceeds 350 millimeters mercury. Finally, with the roller clamp open, prime the dextrose solution to the sterile field, and the sterile person makes the connections, connecting the yellow end of the IV tubing to the yellow connector on the Impella catheter and the red end of the IV tubing to the red connector on the Impella catheter. Once the purge pressure reaches 350 millimeters mercury, the console goes into the third screen. Step 3, de-air. Visually confirm fluid exiting the motor and open pressure port. Squeeze the white flush valve. After 10 seconds, the black line reaches the right side of the display console and beeps and goes into its fourth screen. The console will display, quote, "The Impella is ready to be inserted." This message will only remain on the screen for 10 seconds. The Impella catheter is now ready to be inserted. We'll discuss the steps for inserting the Impella catheter next. 1. Obtain femoral access. 2. Insert the 0.035 provided guide wire. Remove the needle and insert the 6 to 8 French dilator to pre-dilate the vessel. Remove the 6 to 8 French introducer and insert the 13 French peel-away sheath with its dilator. While inserting the 13 French introducer sheath, hold the hub to support the shaft of the introducer to slide it into the artery. Next, administer heparin to achieve an ACT of 250 seconds. Once the desired ACT is reached, remove the 13 French dilator. And insert through this a 6 French diagnostic catheter without side holes into the 13 French introducer over the guide wire into the left ventricle in a standard fashion. Next, remove the wire, leaving the catheter in the left ventricle, and form a curve or bend on the wire provided in the kit. This is the 0.018-inch, 260 centimeter placement guide wire, which is inserted through the LV catheter and is exchanged for the Impella catheter. The wire remains in the LV. the diagnostic catheter is removed and the impella is inserted over this guide wire. To do this, wet the cannula with sterile water and backload the pigtail section of the catheter onto the placement guide wire. When backloading the wire, gently hold the pigtail and feed the wire through the pigtail's distal tip. Limit the handling of the distal tip to prevent damage to the inlet just proximal to the pigtail. Next, rotate the catheter until you are able to visualize the inner radius, which is the black line running the length of the catheter. Straighten the cannula to assure that the guide wire exits on the inner radius of the catheter. Always advance the impella catheter under fluoroscopy. You will then advance the catheter through the hemostasis valve into the femoral artery and along the placement guide wire and across the aortic valve using fixed exchange wire technique. Follow the catheter under fluoroscopy as it is advanced into the ventricle. Be careful not to coil the guide wire in the left ventricle. Verify that the pigtail and inlet are in the left ventricle and the outlet and motor portion are in the aorta. The impella console should display an aortic pressure tracing. To prevent device failure, do not start the impella 2.5 catheter until the guide wire has been removed. After removing the placement guide wire, start the impella device. To transfer to the B-Braun configuration, please follow these steps. Set up the sodium chloride bag with the pressure bag and the 96-inch straight IV tubing. Inflate the pressure bag to 300 millimeters mercury. Clamp the Y tubing and then disconnect the red male port coming from the Y tubing to the red pressure port on the red impella plug. Clamp and cap this. Create a slow drip from the saline pressure bag to flood the luer connection of the pressure port to displace any air and connect. Open the roller clamp fully. The console may alarm during this step. Press signal key on the console until purge pressure screen is displayed. Turn on the Braun Vista pump and choose New Therapy and enter 7 cc's per hour for the starting rate and select VTBD to input the bag volume and then press OK. Open B-Braun door by pressing the latch on the top right of the B-Braun device. Now thread the purge IV tubing through the path of the B-Braun Vista pump. Shut the door. Next, press Start on the B-Braun Vista pump. If needed, give 0.5 cc bolus until the purge pressure is above 300 millimeters mercury. Adjust the flow rate to maintain purge pressure between 300 and 700 millimeters mercury. Finally, deflate the purge pressure bag and remove the D20 from the pressure bag. At this time, add heparin to equal 50 units per cc to this bag. Steps for replacing the B-Braun Vista purge tubing and changing the volume to be delivered, or VTBD. We will now demonstrate how to prepare the new purge tubing, replace the old purge tubing with the new, and reset the volume to be delivered, or the VTBD, on the infusion pump. When replacing purge tubing, complete this operation as soon as possible. The recommendation is the replacement process should be completed within 2 minutes. Refer to the instructions for use for a complete list of warnings and cautions. The required components for tubing change are 1. The B-Bron IV tubing, 2. The Combitron's monitoring set, and 3. 20% dextrose solution. Please follow the following steps. Prepare a 20% dextrose solution with 50 units of heparin per milliliter. Connect a new Vista infusion set and Combitron monitoring set, then connect to the 20% dextrose solution. Flush the purge tubing manually and close the roller clamp. Press the B-O-L on the infusion pump and enter a bolus release of 0.5 to 1 milliliter. Press OK to start the bolus. When the purge pressure on the Impella console reaches 600 millimeters of mercury, stop the bolus. Press the red stop key on the infusion pump to stop the infusion, then close the roller clamp. Disconnect the current Combitron monitoring set from the catheter at the yellow check valve and the gray pressure cable. Open the door to the infusion pump. Remove the current purge tubing. Connect the new Combitron monitoring set to the catheter at the yellow check valve and the gray pressure cable. Open the roller clamp. Load the new purge tubing into the infusion pump. And close the infusion pump door. Once the change has occurred, the new tubing is threaded through the infusion pump. You will press the VTB to enter the new bag volume. Press C on the keyboard to clear the remaining volume, then enter the volume of the new bag. Press OK to accept the new value. Press green Start button to start the infusion. Press the BOL on the infusion pump and enter a bolus release of 0.5 to 1 milliliter. Press OK to start the bolus to increase purge pressure back to normal operating range. If the pressure on the console reaches 600 millimeters mercury, press Stop on the infusion pump. Normal operating range is 300 to 700 millimeters mercury.
Welcome to Abiomed. This training video is designed to demonstrate the removal of the 13 French peel-away introducer and the use of the repositioning introducer. This does not replace the instructions for use manual. Attach a stopcock and flush the repositioning introducer prior to advancing the introducer. Be sure that the stopcock is closed after flushing to prevent bleed back. Place 2 dead-end caps on the stopcock to prevent further usage. The side port should not be used to give medication or draw blood because the blood could potentially clot. Pressure bags should not be connected to the side port of the repositioning introducer. Carefully flush the side arm of the 13 French introducer and be sure the stopcock is closed after flushing to prevent bleed back. Then remove the 13 French peel-away introducer completely from the artery over the catheter shaft and apply manual pressure above the puncture site. After the 13 French introducer is removed from the artery, grasp the 2 wings and bend back until the valve assembly comes apart. Continue to peel the 2 wings until the introducer is completely separated from the catheter shaft. Slide the repositioning introducer over the catheter shaft and advance it into the artery to the yellow eyelet. Secure the yellow section of the repositioning introducer by suturing it to the skin using the provided eyelet. Slide the proximal end of the anti-contamination sleeve onto the yellow section of the repositioning introducer. Lock the anchoring ring in place by turning it clockwise. Secure the catheter shaft in place by tightening the connected anchoring ring. Carefully extend the anti-contamination sleeve to maximum length and secure the end by tightening the distal anchoring ring.
So these are the catheters we use for routine coronary angiography. This is called the left Judkins, right Judkins curve, and a pigtail curve for obvious reasons. And we're going to start with our coronary catheter, left Judkins, and introduce this, change it out for the right Judkins, and lastly for the pigtail catheter. Okay, here we go. What you can see is we're introducing our guide wire to our catheter, and then we'll get it almost to the very end like that. We'll introduce it into the sheath here. Okay, let's just do it like we regularly do. Okay, wire's up, left Judkins up, and we're now moving up the aorta. So let's take a picture. Okay, follow the tip there, please, Russell. Okay, come down a little, Russell. There we go. Okay, and the guide wire is moving across the arch, and it will sit there. We'll stop, take the guide wire out with our wiping technique, and in our lab we have the assist injector, but this would be the place where a regular hand injection manifold would be hooked up. And we flush it by simply aspirating from the patient, make sure there's no air bubble, turn off for the patient, and eject the air bubble that is in the connection here. One more, there you go. Okay, back on pressure, which we're looking at on the monitor behind you. So now we're ready to take our first picture. Okay, let's fluoro. And we're going to introduce the catheter into the coronary artery now. Let's take that catheter out, straight out, and we'll put up the right Judkins. We're just going to do a straight pull. And there's a flush there for you. So we're going to go back now with the next catheter, coil that up. Thank you. Okay, here we go. Wire's up. Follow the wire. Easy. Go ahead. Very good. Okay, wire's out. Go ahead and hook up. I'm going to change to the RCA setting. Okay. Okay, so let's take a look. Come down a little, Will. You have to bring the catheter down a little. Okay, good. Cine? Perfect. Stick. Who did that? Okay, good. Flush that for me. Okay, we're going to take a picture of the ventricle next. Okay, our pigtail catheter is going up. Yes, please. Okay, Russell, 9 tubes, follow us around. Go ahead, Will. Okay, push over. Take it right in. Got the wire too if you need the wire. You're there, you're there. Okay, watch your rhythm. Okay, here's your hookup.
You said ATW wire?
ATW is fine. And I need to know when the angiomax is on its way. Okay, thank you. Okay. Hang on. Okay. Let's have pressure.
Okay.
All right, here's our
Zero.
hands off. We're going to give you a 0 first. Can you 0 for me? Thank you. Pressure's up. So this is our left ventricular pressure, and we're going to talk more about hemodynamics in one of our subsequent sections on this video. Okay. Could you give me high scale, please, at 50? Thank you. Okay, let's set up for a V-gram. Very good. Okay, watch your rhythm. Don't go too far there, Will. Okay. Good. Hold your stuff. Documentation of the procedure following cardiac catheterization is essential for several reasons. It is important for the operators in the future to know what was done. It is important for the doctors who are caring for that patient currently to know what was done and what the results are. And it's important for the administrative people in the hospital and in the cath lab to be able to appropriately bill for your procedures. Documentation of the procedure should include correct demographic data, indications for the procedure, a brief history, a brief description of physical findings, then a listing of the procedures performed, a listing of the results obtained, identification of any complications that occurred, names of the operators, and a final summary note with findings and recommendations. Remember that as a cardiac cath physician, these are only recommendations and not orders. The patient is then prepared for discharge from the cath lab with his findings and instructions and orders for fluids and recovery. These important documents are the key to a successful procedure.